Good afternoon, Melissa. Thank you very much for joining us. Welcome to all of our TFC members to our monthly members call. We're very honored today to have Melissa Harris join us to give us an update on the settings rule. Melissa, as many of you know, is the Deputy Director of the Disabled and Elderly Health Programs Group at the Federal Centers for Medicare and Medicaid Services. And what we thought we would do is have Melissa update us for the first 15 minutes or so. And we asked you to submit any questions that you had for Melissa in advance, and many of you have. And so when Melissa is done with that update, I will ask those questions that you've submitted, and we'll get through as many of them as we can. So for the sake of time, let me now just turn it over to Melissa. And again, thanks for joining us today.
Thank you, Scott, and thank you, Ashley. And it's really my pleasure to be with you this afternoon or this morning, depending on your time zone. I think I last talked to you with any numbers in person at the Misericordia campus, maybe 2 years ago at your 2018 conference. And that was really some time well spent for me to be able to have an in-person conversation with so many of you, to have you hear from me about my federal perspective on the HCBS Settings Rule, but equally, if not more important, for me to hear directly from you, from your perspectives on how the settings rule was being implemented across the country, the decisions that CMS was making, the decisions that the states were making, your concerns, successes, fears. And a lot has changed in 2 years. I don't think any of us really could have foreseen the way things would turn out. And so I think what I'd like to do today is to give you a lay of the land in what CMS is doing as part of our response to the COVID-19 public health emergency. I'll spend a little bit of time talking about our response at a macro level, but then I'll pretty quickly drill down into how that impacts implementation of the settings rule. I understand that's top of mind. So CMS has been fully functional every day since the public health emergency hit. Our life looks very different, and I'm sure the lives of all of you are very different than they were 6-7 months ago. I have been on full-time telework since the middle of March, as has all of my colleagues at CMS. We moved very quickly to a totally remote workforce. And luckily, we were able to do that and still be able to function at the federal level. But even that, even sustaining the workforce at very critical levels at the federal, state, provider, advocacy group level has been challenged given the public health emergency. And a lot of people are working very differently, working very hard, and really rising to the occasion. And that's a success in and of itself, even though things are so much more complicated these days. And so early on in the public health emergency, we started meeting with each state individually and then all states in the aggregate. We've had what was first twice weekly, and now we're down to once weekly national all-state calls to really give us an idea of what the states needed from us on a one-on-one basis and then in the aggregate. And because this is a formal declaration of a disaster, a public health emergency, there are some avenues of relief that are available to us that we can bring to bear for states to remove some requirements that otherwise would have existed and would have required some jumping over hoops that in a public health emergency, just to add to the time spent that nobody had to deliver services. And so we developed a toolkit that's on our Medicaid.gov website, and I'll plug that a couple of times. You can find the whole itinerary of tools that are available for state Medicaid agencies to use, sometimes that allow very targeted relief from federal authorities, and other times allow some pretty general and broad sweeping temporary waivers of federal requirements. Many of you are familiar with the Home and Community-Based Waiver Authority in Medicaid that authorizes a lot of the long-term care services that individuals receive in their homes. And there's also a particular flexibility in that waiver authority that almost every state has availed themselves of during the public health emergency to get some temporary flexibilities approved from CMS that allow them to alter the services that are being provided, in some cases alter the providers who can deliver those services, in some cases use telehealth or move to more electronic capturing of information like care plan development and signatures. So I always say, as I'm having a conversation to Medicaid stakeholders, I always say how important it is to understand how your state is implementing the Medicaid program. And that's just as true now, if not more true now than ever, because it's the state who is coming to CMS to seek relief under one or multiple of these temporary waiver authorities. And that could really be implementing how the Medicaid program is being carried out during this public health emergency. So it's really worth knowing how your particular state is making use of the federal suite of authorities that are available. There are some things that remain just as they were. The expectation that CMS and the states are providing their typical monitoring and oversight activities remains. The responsibility for states to assure the health and welfare of individuals receiving Medicaid services, that remains. But there are a whole lot of variables that could be happening now within states, across different programs, and across states. And so, we've done our best to be as accommodating to the needs of states as they are more aware of the local characteristics of how COVID-19 is playing out than we are at the federal level. But that certainly has done nothing but increase the amount of variation across the states and really raise the importance level of understanding how your state, is moving forward. I will point out that Secretary Azar tweeted on Friday that he was extending the public health emergency. It was slated to expire at the end of this month, and he indicated on Friday that it's going to be extended for another 90 days. And so that means it will, at this point, expire at the end of January 2021. And so some of those temporary waiver authorities available from CMS are only available during the formal period of a public health emergency or a disaster. And because the Secretary of Health and Human Services has extended the period of the public health emergency, those waiver authorities will continue to be in place. But it's also important to note that CMS has made those flexibilities available to states. States don't have to use them. And even if a state has raised their hand to say, yes, I would like to implement a particular flexibility, they can take it down, in essence, at any time. And so as local conditions are changing and states assessing what kind of flexibilities they do and don't continue to need, there can be changes made at the state or even regional levels. And so again, it's just pretty critical to understand what your state's current plan is for implementing Medicaid and how they plan to continue those flexibilities or change them during the public health emergency. So let me seg a little bit into the settings rule itself. We have been talking all this time about how critical the home and community-based settings rule implementation is and how really key the provider implementation of the HCBS settings criteria is. And that certainly has not changed just because we are in a public health emergency. However, the ability of providers to actually ensure and facilitate the community integration of Medicaid individuals has changed drastically. The ability of states to do assessments on site of providers to understand really how they are bringing the HCBS settings criteria into life has changed drastically. And so there have been some state waiver authorities that we have made available, and we have taken a blanket federal action relative to the settings criteria. So over the summer, we issued guidance in the form of a letter to Medicaid directors and a series of frequently asked questions that further extends the transition period, which would have expired in March of 2022. It extends it out 1 year to now expire in March of 2023. And if you had not seen notice about that, that also is on the Medicaid.gov website. If you go to Medicaid.gov/HCBS, you'll be able to find the whole HCBS homepage that is a really good comprehensive guide to all of the moving pieces in home and community-based services. So again, now the transition period to demonstrate compliance with the settings criteria runs until March of 2023. And we did that for a couple of reasons. The states were coming to us individually and in the aggregate. We are losing time in 2020. Months are passing, and we are not able to do the assessment activities. Providers are not able to do the implementation activities. Beneficiaries are not able to really leave their homes to go into the community. And it doesn't seem like that's going to be ending anytime soon. And we need some relief, from this transition period that seemed like it still had a ways to go, but really required incremental progress each month. And 2020 has just played out so differently than we all thought as the year started. And so that really did make sense to us. And no one wants to have implementation of the settings criteria be rushed or driven by speed rather than driven by really thoughtful engagement of providers and families and advocates and beneficiaries, individuals receiving services. And so in measuring all of that, we decided to extend that transition period for 1 additional year. And we also, through the frequently asked questions, we also made some technical revisions to some of the heightened scrutiny provisions that many of you are probably familiar with. We issued a pretty comprehensive set of frequently asked questions in March of 2019, I think. And this new set over the summer just modified some of the dates that were associated with that heightened scrutiny guidance, and again, pushed all of those out an additional 12 months. So that's one more question for you to bring to your conversations with your state. How are you implementing the additional year that CMS has given you to achieve compliance at the state level and to ensure that all of the providers are achieving compliance with the settings criteria? And then, beyond that kind of national step that CMS took, there are a couple of these temporarily available disaster-related waivers that directly impact the settings criteria. One of them is for states that are implementing the 1915C home and community-based waivers, which is all states really. A state can request in a particular disaster filing for CMS to use enforcement discretion about compliance with the settings criteria that indicates that a beneficiary needs to be able to have visitors at any time. For so long during the public health emergency, the freedom of movement of not only individuals receiving services, but their friends and family and support network was really constricted, and people could not just show up the way they could. And one of the key requirements of the settings criteria, particularly if you're in a residential setting, like a group home or an assisted living, is that you have the right to have people come to your home at any time. And during this pandemic, that just was not the reality. And so rather than waiving that provision in the 1915C waiver program, we authorized enforcement discretion to say it just doesn't really apply during the public health emergency. And I should say that this enforcement discretion really only applies to settings for which the regulation is live right now. And so those would be settings that came on the scene after the effective date of the final regulation, which is March of 2014. The rest of the settings are under the transition period that now doesn't expire until March of 2023. And so there's no expectation that those settings really are adhering to the settings criteria. But for those newer settings, for which adherence is expected right now, the ability to adhere to the settings criteria in a public health emergency became a whole lot more complicated. And so enforcement discretion exists to the extent the state requests it for that one singular criterion of visitors at any time. And then for states that have home and community-based services operating in different authorities outside the waiver program, and even those C waiver states that wanted a little bit broader relief just beyond the visitor criterion, we did authorize a waiver authority for those newer settings that are supposed to be complying with the settings criteria. A state can request to essentially waive the settings criteria for this time. You can imagine that that decision was not entered into lightly. We have been banging a drum quite loudly about the wisdom of the settings criteria, the person-centeredness of the settings criteria, and really the linchpin that this criteria serves to facilitate community integration. And it speaks to what a different life we're all living, at least temporarily, that we have this time-limited waiver authority that we have authorized to waive the settings criteria. It's worth pointing out that this waiver authority is only available because we are in a period of disaster, or in this case, a public health emergency. Otherwise, CMS would not be able to, quote, waive the settings criteria. But because we are in this formally declared period of public health emergency, we have some options for relief that are available to us that are not normally. And so it's that authority. It's called 1135. It's section 1135 of the Social Security Act that kicks in times like this and allows CMS to authorize waivers of things we otherwise couldn't waive. And that's the case now where flexibility is key. So not every state has requested to waive the settings criteria. And so it's also worth knowing whether your state has received that kind of waiver and what that means for the implementation of the settings rule inside your state, both during this period of public health emergency, which again will now last until at least the end of January, and then on an ongoing basis, and how your state intends to try to make up some of the time lost, and whether or not any decisions have changed about how the state was going to authorize home and community-based services before COVID-19 and after. I think it's safe to say that all of us are watching and learning and figuring out what lessons should be built into our actions moving forward, as we try to determine how really to offer long-term care services within our states and across pretty divergent populations. So the last thing I'll say before I end and open it up to questions is that we've been engaging for some time at the federal level on a philosophy called rebalancing. And that is, kind of a phrase that was coined that's a little bit of a misnomer. It really means to authorize more long-term care in the community as opposed to an institution. Rebalancing connotes that we're trying to get back to a place where we were before. And that's really not the case here. I think, we can all agree that we've been pretty heavily reliant as a nation on institutional care in the long-term care space for a long time. And it wasn't until fiscal year 2013 that the balance between community-based care and institutional care really, came to the forefront in terms of the number of dollars spent for community versus institutional services. And we really want to keep that trend moving. And so we are kind of renewing our efforts at the federal level and in our negotiations with states to say, what are you going to be doing moving forward as you also watch and learn and learn lessons from COVID? Are there particular settings that need to have a stronger role in your long-term care service provision? Are there settings that need to have a different role moving forward? CMS does not have a one-size-fits-all answer. That never works. You all know that, just as well as anyone does. And so we're quite interested in learning from what the states are seeing. The states will come to us as they choose in their own time with the various the experiences that they've learned over COVID, and they'll hopefully propose some actions to us to further any progress that might have already been previously made. Person-centered planning is going to remain very key, recognizing that each individual is different and requires a different level of supports and services, whether they are funded by Medicaid or not. Some individuals have some really significant service and supports needs, and it's a valid question of how those needs are going to be met and what providers are in the best position to meet those needs. And so no one is looking at curtailing choice or restricting individuals to receiving services in a smaller number of settings. But it's an interesting time to be having a conversation about long-term care in this country, because things have largely been turned on its head, and it'll be kind of fascinating. But this is a real life discussion that is impacting people daily, and so we need to be having these conversations efficiently and with an eye towards what needs to happen at the state, federal, and local levels, to really make sure people have the right array of choices that are laid out in front of them, and that they have the ability to meaningfully choose among those options. So let me stop there. I will do my best as we move into the Q&A to have some profound response right now. If I can't answer a question, I will at least write it down and try to take it back to a colleague. But we have about 35 minutes, I guess. And so I'm quite interested to hear what's on your mind. But again, I really thank you for having me today.
Great. Thanks for that update, Melissa. And so let me start off with some of the questions that have been submitted. And I want to start with some that are COVID related. And the first question really takes us away from the settings rule. And maybe it's in an area that's not even yours, but we're all hopeful that in the near term, there's going to be a vaccine available. I think we all understand that there's going to be limited supply at the outset, and so there has to be a prioritization as to who gets the vaccine first. And I'm wondering what involvement CMS has or any input it might have in setting those priorities.
That's a front burner question, isn't it?
Yep.
And so, largely CMS is going to be deferring to our colleagues at the CDC. They have not only the clinical background, but they also have the logistical and operational background of actually deploying a vaccine. Now, this is new territory. That's worth saying, as many times as necessary, where a new vaccine is being developed and needs to be pretty universally deployed. This is not for, necessarily targeted populations. And so, I think like a whole lot of people, I'm quite interested in how this actually plays out. The CDC has been developing, I think the term they call it is a playbook, although I wouldn't quote that. And they have spent time deciphering how best to roll out in waves a vaccine. And so I won't get into their territory because I don't want to quote a document that might now be outdated. But I know they are actively thinking about that. And so I think so much is going to depend on the timing of when a vaccine is available. Like you, I am hearing that some of the vaccines under development might take 2 doses. So, at what point, at what interval, will the second dose be made available to people who have already had the first dose versus the first dose being made available to a wider swath of people? Those are all relevant questions. Certainly I've heard anecdotal questions about, will people who are prioritized those are all questions that the right people are working through. And that information is not by and large going to come from CMS, but it is going to come from CDC. What we've been doing, we are spending an awful lot of time talking about the rollout of the COVID-19 vaccine and how it is going to be offered and reimbursed under the Medicare program, Medicaid, the commercial market exchanges. And so you can look for guidance to come out of CMS in the nearer term. I mean, this is obviously priority work that really talk about some operational issues for states and managed care plans and providers about how those three programs, Medicare, Medicaid, and the commercial market, will be covering and reimbursing for the administration of the vaccine, the types of providers who are going to be on the front lines. Some of that will also be determined by the logistics of administering the vaccine. I am not a scientist at all, but it seems like there might be some, pretty interesting requirements for the storage of the vaccine. And so that might have an implication on the types of providers who can actually administer it. All of that information will be made clear when things are a little more solidified, and then CMS will piggyback on that to talk about coverage and reimbursement in our three programs. But I would really keep up to date with the CDC guidance because they are really on the front lines of not only the development of the vaccine, but the distribution of it as well.
Yeah, I think the concern, obviously, of our membership, since we're representing folks with intellectual and developmental disabilities, and I think the data shows that that's a vulnerable population with respect to the virus, that there'd be somebody advocating for the early administration of the vaccine to that population. There's a lot of talk about the elderly in nursing homes, and the situation really isn't terribly different for folks with IDD in residential settings. And so is the CMS sort of in there advocating for our group, or is that something we need to be doing ourselves? And who is it do we need to be talking to about that?
Well, I don't know that there can be too much advocacy in this regard. CMS is raising our hand to say, there's a whole lot of different people who are receiving Medicaid funded home and community-based services. There's a whole lot of divergence across the age span, across the type of disability that people might have. You're absolutely right. The nursing home population is getting a lot of airtime. And there are reasons for that. But you're also absolutely right that there are a whole lot of people that are just as vulnerable in different settings. And so we are making that point. Any kind of, direct contact that you want to be having with our CDC colleagues, I would never discourage you from doing that. I think reinforcement of that point is always a good idea.
Has COVID affected CMS's interpretation or application of the settings rule, especially with respect to intentional communities, such as the Camp Hill communities? These intentional communities provide a lot more than just a residential setting or a vocational setting. They are a community in themselves, but because of the way they're organized, they often maintain safety for their folks, protecting them from the virus. And so we're just wondering if the virus has at all impacted how CMS is viewing intentional communities.
If we were to, even go back 12 months and have this conversation, I think I would find myself reiterating most of the same points, which are that, there is no fundamental reason why an intentional community could not become a setting that is compliant with the HCBS settings criteria. As we talked, at length a couple of years ago, we CMS have had, a bit of an evolution around intentional communities and the recognition that each setting should be evaluated on its own characteristics by the state. Each setting should have its own decision made about whether that setting will require heightened scrutiny. Sometimes that decision might be more cut and dry if we're talking about a setting that's on the grounds of or adjacent to a public institution, or if we're talking about a setting that is inside a public or private institution. But the changes that have happened to the definition of isolation that were publicized in our March 2019 FAQs, that still carries the day. And so each setting, even looking now through the lens of us being kind of wizened and impacted by COVID, each setting should be evaluated on its own merits. And a state can say, I've looked at this particular intentional community. It does not meet the definition of isolation. It does not have an institution on its campus. And so it doesn't hit any of the three categories of a presumptively institutional setting. It won't come into CMS for heightened scrutiny. I, as the state, am just going to make sure that it actually does adhere to the settings criteria by the end of the transition period. That's one pathway that could happen. It also could be that the state does an assessment of a setting and says, I do see some characteristics here that meet the CMS definition of isolation. I'm going to work with that setting to remediate out of those. One of the things that we changed in our FAQs this last summer was the July 1, 2020 date that was so prominent last year in 2019 as we issued those FAQs. One of the major elements of our March 2019 FAQs was to say that a new flexibility was to kind of split the remaining transition period in half and say that, to say that if a state had assessed a particular community as being isolating, but could make a determination by July 1, 2020, that the setting had remediated out of being isolating, that setting would not need to come into CMS for heightened scrutiny. Well, the July 1, 2020 date got kind of blown up, as 2020 was passing. And that was one of the things that the states were saying to us as they were making the case for us to extend the transition period. And so one of the technical points that we did in the summer 2020 FAQs was to push back that July 1, 2020 date also by 12 months. And so now, if a state were to re-engage on their settings assessment functions and determine that an intentional community or any kind of setting did meet elements of that definition of isolation, the state would have until July 1 of 2021 to bring that setting into compliance without having to submit that setting in for heightened scrutiny. And so, in a lot of ways, the story is the same now as it would have been last year. It's really each setting is in control of its destiny in terms of whether it is going to ultimately be in compliance with the settings rule and whether it's going to ultimately require heightened scrutiny. I still certainly stand by the premise that heightened scrutiny is not a mark of failure in and of itself. It just means that there is going to be that second look by CMS on top of the state assessment. But a lot of settings are coming into CMS because there is no way around it. A setting that is inside a public or private institution, or like an assisted living wing of a nursing home or an adult day center wing of a nursing home, those settings have to come into us for CMS, for heightened scrutiny. A cottage setting on the grounds of an ICF, that setting has to come into CMS for heightened scrutiny. For the isolation component, it's a bit of a mixed bag. Some might come into CMS for heightened scrutiny, some might not have to. And then we take each one as it comes and evaluate it on its own merits. There's been a big slowdown in heightened scrutiny submissions, as you can imagine, the last several months. And so that will pick back up again as states are again able to turn their attention to some of the activities they thought they'd be doing earlier this year. But intentional communities, I think, each one is individual, and how well positioned each setting is to be in compliance now with the settings criteria is really going to be an individual assessment. But, and I imagine that a lot of your attention has been diverted to really an all hands on deck COVID response. And that's as
Sure.
it should be. But to the extent that you also can start, taking a longer look at, getting back to the business of doing your own self-assessments and working with your state to do provider assessments. It's with that same goal of demonstrating compliance with the settings criteria, which, there's no reason can't happen.
You touched on this a little bit in your opening remarks, but just wondering if, in light of, again, of the pandemic, does CMS have any new rules or initiatives regarding the use of technology, either for telehealth or for, access to family and friends, however technology might get used in an HCBS setting?
Telehealth has seen, a pretty big explosion, in the last several months. It's been pretty amazing, actually, to watch. And CMS has been very encouraging of it. But we know that there needs to be some thought that goes into the role of telehealth moving forward. It's really been a lifesaver, as typical settings in which a lot of the services were provided have been shut down, or at least the individuals don't have the same in-person access to those settings as we used to have. And so the gap filling that telehealth has done to get services to people and minimize any delays and disruptions in care has been really great to see. That required an awful lot of work on the part of states, on the part of the providers themselves, to really turn very quickly and pivot from an in-person care delivery model to an electronic one. And technology is awesome when it works, and when it doesn't, it can be the devil. And so different parts of a state have access to different types of technology. Sometimes the states themselves had some restrictions on the types of services that could be offered during using telehealth, or the types of providers who could furnish services using telehealth. The good news is that there really were no federal barriers, because there is nothing to restrict the use of telehealth in Medicaid at the statute or regulatory level. And so states didn't need really any special permission from CMS to be able to really grow the use of telehealth and remote technology. In some cases, they needed to amend their Medicaid state plan if they had some limiting language in there. And in some cases, they needed to amend how they were going to reimburse for a service authorized over telehealth. But the door is pretty wide open in that regard. Now, we all know that not every service can be delivered using telehealth with the same quality standards. If you need physical help to get out of bed and use the bathroom, it's very hard to translate that into some kind of virtual platform. But there's an awful lot of Medicaid services that can be delivered very well remotely. And we're all for it, as long as the state is continuing to do their typical monitoring and oversight, and provider credentialing to make sure that the providers who are furnishing the service are really qualified. The technology costs are a thing. It's not a switch, that the technology is there. Some services require equipment to be in the home of the beneficiary and in the office of the provider. Deploying that kind of that equipment, also brings some logistical challenges. And then there's also the availability to provide some home and community-based services using things like assisted technology and things like that. Anything that's a communication enhancer, is generally, to the good. But we do want to make sure that we don't become so dependent on technology that we have a whole new slice or flavor of isolation. There is a bit of a danger, in going a little too far into the other direction and having everything kind of come into my home in the form of my computer, and I never have to go anywhere. That can be temporarily a very good thing, in a public health emergency. In the long run, though, it can have some detrimental side effects in terms of, again, furthering isolation, having you be a little less connected to your community and your family and support systems. So the trick is finding the right balance. And particularly as we, at some point, really do come out on the other side of this public health emergency, what the proper role is for telehealth, I think it's going to be in part a national conversation and in part a state and local conversation, but it certainly has carried the lion's share of responsibility in ensuring that services get provided, during this pandemic. But it's something that we need to make sure is used in the right way and doesn't, kind of get us into another, sticky spot that we have to backtrack from a little bit.
Sure. And then one final COVID question. Does CMS have any new requirements regarding infection control in HCBS settings?
Federal standards for infection control are really limited to institutional settings, nursing homes, hospitals, ICFs. And you can imagine that there has been a lot of focus on infection control the last several months. Never was it really a back burner conversation. And there are conditions of participation that are in the federal regulations for those types of institutions. Not so much on the home and community-based services side. And, we may have talked about this before. The federal infrastructure to evaluate care in institutions versus home and community-based settings is very different. If you look at the Medicare and Medicaid statute, there is a pretty formal infrastructure in place to have a partnership between the federal government and state survey agencies. And those people are going into the physical footprint of those institutions. And even though they are state level employees, they're really, kind of looking at things through the lens of compliance with federal conditions of participation. And the federal government uses those findings to determine our own next steps. Is there a corrective action plan? Is there a financial penalty that's going to be levied on that institution? We don't have that same infrastructure at all on the home and community-based services side. So the state in their waiver application will describe for us how they are going to be overseeing the operations of their waiver providers, be they residential providers, be they non-residential day providers. And the state is on the hook for describing to us in the waiver applications how they're going to ensure the health and welfare of individuals. The clinical aspects of infection control in a group home, in an assisted living, that's more likely going to be found in the licensure requirements that the state oversees. There's really very little federal involvement with that. And so it does become pretty stark, the differences between institution and home and community-based services. And it raises some pretty existential questions about, should the federal oversight of home and community-based services be different? Do we replicate what's in the institutions? Should we? What are the dangers of doing that? What are the benefits of doing that? What would it take to even think about doing that? Would it require legislative change? Would it require regulatory changes? Those are some pretty heavy requirements to think about changing, but they are relevant questions. And so in the HCBS space right now, we are, we oversee the states who oversee the providers. And so the relationship is a little less direct than on the institutional side. But certainly, the need to keep people safe and reduce the risk of infection spread has never been more important. It's certainly a shared goal at the state and the federal level, and by all the people who are operating provider organizations, to do the best they can. And it's going to be interesting to see what changes come on a more technical basis to those, to see if there are any revisions that need to happen to the infection control procedures, and watching, on the other hand, how to balance that with the need to protect the emotional well-being of people to facilitate the engagement of individuals with people that they are living with their larger community. Sometimes those things are at odds, and finding the right balance there is going to be key.
Let me turn to another topic that's top of mind amongst everybody. Obviously, we have an election that's 4 weeks from today away. And since you've been at CMS for 25 years, you've obviously been through a lot of transitions and changes in administration. We don't know if there will be one this time around or not. But if you can maybe just on a practical level talk to us about how a change in administration might affect the work at CMS with respect to the settings rule, for example, and if we wanted to express our views to any new leadership at CMS, when is the appropriate time to start trying to do that?
You know, it's been my experience. So let's. I mean, there's two possible choices, right? There is a change in administration. There is not a change in administration. So if there is not, then there's still always the potential that individual bodies could still change. Our administrator has been with CMS for the last 4 years. That's not always the case. You know, we can have some changes at the administrator level. There's been stability there for the last 4 years. Would that be the case in a second term for the current administration? We find that out together. And so, you know, even if the current administration, you know, retains the election, there could be a change in individual people. And so if that happens, there's always the ability for you to request a meeting, you know, with whoever the new people are, to say, this is who we are, this has been our prior work with CMS, et cetera. If there is a change in administration, then the number of new people is just going to be much bigger. And you'll have, you know, people at the administrator level who will be different, people at the CMCS director level who will be different. And, you know, I would certainly encourage you to say, you know, if there's a whole new crowd of people, you know, to reintroduce yourselves. It generally takes some time meaning anywhere from a couple to a few months after a change in an election for those chairs to be filled on a permanent basis. That's just kind of the, you know, the nature of things. Some of those positions, a lot of those positions are politically appointed, and oftentimes there's a cascade effect of, you know, the administrator is selected first and then he or she selects some of the other people. And so it's not uncommon to find a lot of people in acting capacities. And in fact, you know, I don't know how widely known this is, but the fellow who had been leading CMCS, Calder Lynch, is now acting as the chief of staff for our administrator, Seema Verma. And so he no longer is the head of CMCS. And so in his place, we have a career federal employee by the name of Anne Marie Costello, who's technically one of the deputies in CMCS. She is now temporarily acting as the director of CMCS. And so it's not uncommon also, you know, to have some individual chairs become vacant. And so, excuse me, I don't anticipate any changes in Calder's position or Anne Marie's position in the short term. And then, you know, what happens after the election is something we, you know, we'll kind of all see play out together. But, you know, certainly it's worth, if we're talking about one or two new people, or if we're talking about a whole new crop of people, you know, it will be worth, you know, kind of setting down your priorities, you know, formally introducing yourselves to them, talking about how you have interacted with CMS in the past, you know, things like that.
Sure. Great. Thank you. You know, as you know, Together for Choice, our mission is to ensure that folks have choice in terms of their residential settings, their work settings, et cetera. So I'd like you to speak for a minute, if you could, on how the role of personal choice in application of the settings rule, and what is CMS doing to ensure that choice is respected, whether it's a choice to live in an ICF or a choice to live in one's own apartment or the choice to live in an intentional community.
Yep. And, you know, I know that's been the theme of a lot of our conversations, and it should be. I mean, that should be the focus of really any kind of conversation between stakeholders and the federal government is how do we really make sure the choice is not something that looks good on paper, but is really implemented with meaning on the ground. And so what we say when we talk about the settings rule at CMS is that its foundation, which is reliant on person-centered planning, is meant to bring that choice into the forefront and into reality. Now, what that means, though, is that person-centered planning needs to be done well. If it's not done well, then everything on which it is built is pretty shaky. And so there are some scenarios in which person-centered planning can go pretty smoothly, and then other circumstances where it can be pretty complicated. You know, certainly as the role of the person-centered plan in spelling out what those needs are, who's going to address those needs, what's the role of Medicaid, what's the role of natural supports, what's the role of a state-funded program or a program funded by another federal agency. All of those variables need to come together in a really coherent, integrated way in that person-centered plan, such that everyone who has a part in facilitating that plan knows what he or she is doing and knows the lifting that other people are doing. And as much as possible, the development of that plan needs to be driven by the individual or whoever he or she has asked to help in the development of that plan. And we know that there are some cases, many cases, in which people do need help in establishing that plan. And that's fine. It's a real skill to make sure that the voice of the individual is the one that's carrying the day. And with some people, that's very hard. The realities of that, are clear. But that's why it is so important to make sure that the right people are at the table, the right people are in the decision maker seats, the providers understand what they are doing to help reach the implementation or facilitate the implementation of the plan. But the providers know that it's not their life. They are there to help that person meet her goals, his preferences, his desired outcomes. And so it's not necessarily the provider that's developing the plan. It's the person developing the plan. And so, that's certainly the priority.
When you mentioned, rebalancing in your remarks, I got concerned with respect to choice. And the reason that I am concerned is, what we have found is that at the state level, there are many states where the regulators have a real ideological point of view and do want to push everybody into the community, into small homes or their own apartments, etc. Even though some folks would really have found that they do better in intentional communities, other kinds of settings. And the regulators don't appear to be open in some places to that. And so I am concerned that if CMS really pushes this idea of rebalancing and really pushes states to do more on a rebalancing front, that individual choices are going to get lost, and those who do prefer and do find that they do better in these alternative types of settings won't have access to that choice.
Here's what I would say to that. Rebalancing requires two sides of the equation. And if there is going to be a lessening of reliance on institutions, there needs to be a lot of investment on the home and community-based services side to make sure it is sufficient to meet the needs of a whole lot of people, the whole lot of divergent needs of people. You're absolutely true. It's absolutely true that there is not a type of provider that is going to be able to meet the needs of all people receiving home and community-based services. Having the choice of in-home supports versus day supports versus living in a setting that is also your service provider versus living in an intentional community versus living in an institution. There are people who will need all of those types of supports. And if one of those components of the spectrum is going to be really reduced, then it puts the pressure and the onus on the other points of that spectrum to pick up that role. And so it's not really a win for anyone to reduce reliance on institutions and not have a similar investment in growing your home and community-based services. It's not going to be a win to say, we've walked away from ICFs, for example. If the state does not have any way to care for people who otherwise would have been served in an ICF and meet their needs in the home and community-based settings. I absolutely agree with that. And so it needs to be more than, just a paper exercise. It needs to be more than just an expenditures report to say, look, we actually, tilted the scale more to HCBS as opposed to institutions. It's really, when you're coming down to those individual care planning meetings where you're mapping out what this person needs, what choices are available to him or her that are going to address those needs. And is the person saying, I'm going to select this provider for my services. I'm going to receive my services in this way. I'm going to get my needs met for all these people coming together, Medicaid, non-Medicaid, natural supports coming together to make this plan a reality. That's the true rebalancing. Not saying, here are your options of two, and having neither one of those, really meet your needs. That's not what we're looking for. The choice has to be real, and the supports in the community need to be there for people with even the more challenging and more comprehensive needs. And if they're not there in the community, they need to be somewhere. And so, that's the hard conversation, that we need to have with stakeholders of all stripes, to say, if the supports are not available in the community, they need to be somewhere. Now, if you've got a goal, to really bump up your home and community-based services, that's great. CMS will be right there with you every step of the way, dissecting every Medicaid authority that might be able to, to bring Medicaid funding to the table, saying where Medicaid stops and another program needs to start. That's a big bulk of the TA we're doing. But the choices need to be real, and the investment in the community needs to be real in housing, in employment, in direct service worker availability, and not just for people with low support needs, but people with higher support needs as well. And it's a work in progress, to be sure.
Melissa, I know we're bumping up against the end of the hour. I've gotten through only about a third of the questions that my members have submitted. Would it be okay if we emailed you the balance of the questions, and then at your convenience, perhaps you can provide sort of an emailed response to them? Would that be okay?
I'm happy to take a look at them. These days getting, written cleared responses, out of CMS is kind of a big task. We have a lot of guidance that we're trying to push through the clearance queue. But, once I'm able to see them and figure out what we're talking about in terms of written responses, I can give you a better handle on that. Or we can always, I can always make myself available for like a part two, of this kind of verbal conversation.
Great. Thank you so much for your time, and really appreciate all the input.
Well, thank you guys. I really am glad to have been with you today, and you all have my thanks as well. There's been a lot of people who've had to do a lot of quick pivoting, and I imagine that I'm talking to a lot of them right now. And so, we're all tired. We're all wanting this to be over and life to get back to normal, but we're working hard for a lot of the same people. And it's really good to be with you all today. So thank you for that.
Great. Thank you, Melissa. Bye-bye.
Thank you. Bye-bye.